All right. Well, we're 2 minutes past one, so I think people will continue to trickle in for the next few minutes, but maybe we'll start with introductions. So you all have the great fortune of hearing the wise words of Brenda Kateera today. I'm going to introduce myself briefly, and then I will and let you know why I'm facilitating the talk today, and then I will introduce her and hand it over. So I'm Jessica Cohen. I know most of you in the room already. I'm an associate professor here in the Global Health and Population Department. And I am also the co-director of the Harvard Lead Fellowship for Promoting Women in Global Health, alongside Dr. Bethany Rose, or BR Dobman, who is also in the meeting today and is an assistant professor of medicine at Harvard Medical School and co-directs the MGH Global Palliative Care Program. So the Harvard Lead Fellowship is a really spectacular fellowship program that's co-sponsored by our department, GHP, and by the Harvard Global Health Institute. And it is designed to advance leadership skills for emerging women leaders from low and middle income countries, who we hope in turn will mentor future women leaders in global health. We have an amazing cohort of fellows this year. Brenda is one of 4 out of over 2,000 people who applied for this fellowship. And what she and her cohort will do is work closely with senior Harvard faculty members and personalized executive coaches, and really take this year to have the opportunity to build a custom sort of leadership development curriculum that aligns with their own professional goals and catalyzes their leadership even further. So Brenda is a global health specialist, epidemiologist, and researcher from Rwanda. She's currently the country director for the Clinton Health Access Initiative in Rwanda. And prior to this, Brenda served as the Rwanda country director for the AIDS Healthcare Foundation, the director of research and faculty at the University of Rwanda College of Medicine and Health Sciences, and as a physician at Malago National Referral Hospital in Uganda. Her research focuses primarily on novel methods of HIV prevention, as well as improvements to adolescent health interventions. And we are so thrilled to have Brenda as part of our 2023 cohort and to learn from her rich experience today. Brenda will be in person on the Harvard campuses in the spring semester, so stay tuned for some announcements about opportunities to engage with our lead fellows. Brenda's talk is from Healing Hills to Healthcare for All, Rwanda's Inspiring Path to Universal Health Coverage. I would ask you all to please hold your questions to clarifying questions, but please do, if you have clarifying questions that you think others in the audience have as well, please feel free to raise your hand and we'll call on you. Otherwise, please hold non-clarifying questions till the last 15 minutes of the call. Want to flag for you that unfortunately during the last 10 minutes or so of this meeting, I have to pick up my daughter to take her to a doctor's appointment. So the co-director of the Lead Fellowship, BR, will take over questions at the end. And with that, I will hand it over to Dr. Kateera. Thank you.
Thank you so much, Jess, and it's such an honor for me to be here today with you all, and I look forward to meeting some of you in person next year when I'm on campus. So I'm excited to present the talk on Rwanda's path to universal healthcare coverage. And I'll start off with a personal story. That's a picture of my grandparents who have since left this world. But my grandmom had a chronic illness and of course had to seek several healthcare services, and became terminally ill at some point and had to be taken into intensive care unit and really end-stage life management. But because she had universal healthcare insurance, community-based insurance, the family did not face any financial catastrophes because all her care was catered for by the health insurance scheme at that time. In contrast to my mom, who was diagnosed also with a terminal illness early on in the 2000s in another country, not in Rwanda, and eventually passed on in my early stages of career as a physician. And I think that also exposed me to the challenges within our healthcare system and altered my trajectory as from a clinician to actually a focus on global health and public health to strengthen health systems so that every citizen has access to the right healthcare services at the time when they need them of sufficient quality. And additionally, she was not covered by the health insurance at that time. The country that we were living in didn't have any health insurance scheme, so all her care had to come out of pocket. And the family faced significant financial catastrophes. And this story is not unique to just my mom, but to several other families in Africa that are impoverished by just a single catastrophic event. So today I'll be highlighting on some of the principles of universal healthcare coverage and how Rwanda has managed to achieve the gap towards addressing universal healthcare coverage. So the principles for universal healthcare coverage, UHC, is that all people have access to needed health services, leaving no one behind, without the risk of financial ruin linked to payment for the care that they need. So the services need to be of adequate coverage, not just quantitative coverage, but good quality coverage. And there has to be coverage for financial risk protection and for all leaving no one behind, regardless of the disease or impoverishment level or any other condition. So this is a cube that many of you may be familiar with that covers the UHC pillars, really, in terms of which population is being covered. What is covered in terms of healthcare for them, and which interventions are covered, so that the goal is to reduce the white within the cube and have all of it covered with the blue. So in my outline for today, we'll talk about a background of Rwanda, the health insurance scheme, features that the country has put in place, achievement and success factors, and also highlight some of the challenges that we still face and future perspectives to address those challenges. So Rwanda, like you know, is a small landlocked East African nation, I think around the size of Maryland, currently close to 13 million people. It has the highest population density in Africa, over 400 people per kilometer squared. Administratively is divided into 30 districts, and further subdivided into sectors, cells, and villages called mudugudus, and each village houses around 50 to 100 households. Current life expectancy at birth is close to 70 years. GDP per capita is still less than 1,000, which is still low, and most of our population is employed in the agriculture sector, and actually over 60% we are a very young country. 60% are less than 18 years of age. So this is a picture of the healthcare structure, and it closely aligns with the administrative structure that I talked about. It's pyramidal, like for many other African countries. At the base, at the village level, we have community healthcare workers, currently around 4 per village, that cover the majority of health promotion and prevention activities, and some treatment like malaria and antenatal care services in the community. The next level is a health post, that is really the first level of contact for an individual with the health facility, a structure health facility. And the goal is for every cell to have a health post. We are not yet there, but we are around halfway. The next level is a health center that covers majority of the curative services in the community at the primary healthcare level, before being referred to the district hospital and further up the pyramid for specialized care. So 85% of the diseases are treated at the primary healthcare level from health center and below, and the goal is to reach 95% by 2028. So a little bit of a journey before 2000, really like you might know, we had a genocide against the Tutsis in 1994, and the public health system really collapsed at that time, including any community risk sharing mechanisms. Most health services were supported by international agencies, and there was user fees that were, oops, just go back. Sorry about that. Yeah, user fees were introduced to try and meet sustain the funding for service provision. There was a very high burden of communicable diseases. There was very low service utilization, partly because of the user fees that had been introduced. There were very high levels of poverty, with limited financial resources at the health facilities, and of course, very poor health outcomes. So Rwanda's way of trying to achieve universal healthcare coverage, which the government was very committed to, was to introduce a community-based health insurance mechanism. And this was piloted in 1999-2000 in 3 districts out of the 30 in the country. And the citizens were contributing at the district level and pooling the funds within the district in those 3 districts. There was considerable success, and there was a decision made to scale this up to the rest of the districts, but it was still pooled at the district level. By 2006, we had over 1,000 members that were contributing, which is still very minimal, but was showing that there was a proof of concept. In the 2011, we introduced a national community-based health insurance, CBHI is community-based insurance policy, where we introduced premium based on socioeconomic status and income, and there was co-payments introduced for those that were able to pay, but for the really indigenous population, there were no co-payments, it was free. And patients were able to seek services from whichever health center was in their catchment area, that's called roaming, and they were really able to go anywhere. So because of the premiums that had been introduced at that time, there was a drop in CBHI enrollment, and management was also, financial management was an issue. So in 2015, there was a decision that was made to have all the districts pull together their funding and create one pool at the central level, and the decision was made to move the management of the scheme from the Health Ministry to the Ministry of Finance within the Social Security Board. A new health law was introduced to have mandatory health insurance. So every citizen in Rwanda and every resident in Rwanda needs to have health insurance, whether it's covered by community-based health insurance or any other private scheme. And in 2018, we automated the premium collections for the premiums, which I'll talk about a little bit later. So now that it has been successful in terms of collections, and we still have donors feeding into the pool, we are working towards sustainability of the scheme, and really seeing how the scheme can contribute towards achieving universal healthcare coverage. So I'll talk about some of the features of the scheme now. I talked about the premiums that had been introduced to be paid. There is a national socioeconomic categorization that groups people into 4 categories based on the socioeconomic status. So category 1 is the poorest, and it gradually increases to category 4, that is the highest socioeconomic status in the country. And The premiums are graduated on a sliding scale based on the socioeconomic status. So you have the lowest category that used to pay $2. It's now been increased to $3 per year per person. Category 2 and 3 also pay $3, and category 4 pay $7 per year per person in the family. For the lowest category, their premium is paid for by the government, and then the other members of the families in the other categories have to pay their premiums before they can access care. The lowest category covers around 17% of the population at the moment. What is the scheme able to pay for? What services can the members benefit from? It really covers most of the services that are covered in the public sector, following the cascade, the pyramid of care that I showed earlier. So consultations, surgical interventions, dental care, investigations, and other diagnostics, dialysis for advanced kidney disease, and medicines and other commodities that are needed. Each of the levels has a different package, depending on the level of care that they are able to offer, with the primary healthcare level offering a primary package, and the district hospitals offering a complementary package, with the referral hospitals offering a tertiary and specialized package. There is a strict referral system that controls movement of patients from one level of care to the other level. So it was important that we have all the different stakeholders engaged on board right from the beginning. You have the Ministry of Finance and Economic Planning that was, of course, contributing to the scheme through payment for the Category 1, but also fund mobilization from our partners and donors, and was the overall supervision of the Social Security Board that was in charge of the scheme management. It was important to engage the communities and the local government. This created demand generation in the communities, and still does, through mass mobilization and sensitizations, including door-to-door funds, and to really raise the funds. And also we're managing the socioeconomic categorization and the ID databases that were needed for the civil registry and citizen information. The Ministry of Health was in charge of elaborating on the health policy, putting into place what acts are going to be covered by the scheme, what's the service package, what are the tariffs, what is the coding mechanism, and of course offering the care through the health facilities. And RSSB was in charge of collection of premiums, registration and member management, and providing the benefits and payment of the service providers for the services offered through the Ministry of Health. So since 2020, the government has created new subsidies to make the scheme sustainable. Of course, one of the challenges that we saw with the limited premiums that are collected, that's really not sufficient to offer a full package of healthcare services. And the scheme is still heavily subsidized from donors and government. So government still contributes to the scheme around $6 million per year. And of course, the citizens still contribute $3 per year, depending on the category they're in, $3 to $7. So we had to think of other innovative sources of funding in the revenue raising for the scheme. And in the bottom level of the slide, some of the innovative ways of financing that we supported the government to put into place. So every salaried employee contributes a percentage of their salary. 50% of the medical research fees goes towards the scheme. Pharmaceutical product registration, 10% of the services offered to gaming companies goes to the scheme. from motor vehicle inspection, road traffic fines, telecom companies, fuel companies, other private health insurances, all contribute towards the scheme. And this has raised the amount of money that the scheme is able to operate with, and not go into a deficit. The other key factor has been leveraging the power of technology. So we've introduced a digital premium collection. So previously, community members, citizens would have to carry the cash to the district center, where a member of the Social Security Board would be seated, receive the cash payment, and make a receipt out, with no automation. But automation has really eased the process. So in the comfort of my home, I'm able to access the RSSP payment system for the community-based health insurance, make my payment, verify status of my family, and also check member eligibility and other requirements that might be affecting my CBHI as an individual. And that has really eased the collection, but also eased access to registration into the scheme. And during COVID, when there was lockdown and the citizens were still not able to move around, we never saw a drop in premium collection, because of the digitization that had happened just before. Of course, there were risks that were associated with introduction of the scheme. One of them is adverse selection, where people with higher risk would be the ones to enroll and adhere to the scheme, while healthy individuals would not adhere because they didn't perceive themselves to be at risk. So some of the mitigation measures that we put into place was, it was mandatory for everyone to have health insurance, and an individual would not enroll as an individual, but rather as a household, so that every member of the household is covered, whether they have a higher risk of getting sick or not. The other risk was on the moral risk and cost escalation. It would be easy to take advantage of the benefit package or even abuse them, and of course the increasing cost of medical care that we are seeing. So some of the mitigation measures was to introduce a co-payment. At the primary healthcare level, it was $0.2 and 10% of the bill at the hospital level. The CBHI staff would also verify the invoices from the health facilities, and do counter verifications to ensure that the invoices are accurate. And of course, the standardization of protocols and guidelines that needed to be followed, and prior authorization for specific acts or procedures. So in summary, Rwanda's approach to UHC was to, in addition to have health insurance, these are some of the critical factors that enabled the scheme to be successful. We see that citizen ownership and participation is very critical. It's still a voluntary scheme, much as having health insurance is mandatory. People can opt into having community-based health insurance or any other form of insurance. So it's really important to have the demand generation and keep the citizens engaged and aware of what's going on. And this is where the Ministry of Local Government comes in. Of course, if they pay for healthcare services through health insurance, the services, when they go to the health facilities, have to be available, they have to be accessible, and they have to be of good quality. So there has to be the health system responsiveness and accountability measures that are put into place. And in Rwanda, we have a performance-based mechanism where even the local leaders, the health facility leaders, have performance contracts with the citizens and with the government for accountability purposes. The scheme is still contributory, but we also have the direct taxes that are enabling the pooling of the funding. Government coordination is still very important in all of this, and leadership as well. And there has to be avoidance of duplication in financing for the different services that are offered. Equity is important. We have to leave no one behind on this journey towards universal healthcare coverage. I'll shift towards what are some of our achievements and success factors that we've seen since we introduced the community-based health insurance and other UHC improvement reforms in the country. In terms of our coverage rate, when we started very early on in 2003, it started from 7%. I'm glad to report that right now the coverage of the health insurance is over 87%. For the CBHI and private health insurance is around 4%. So total insurance coverage in the country is close to 91%, which is a big success. Of course, we still have the 9% that are not covered by any health insurance and have to pay out of pocket if they get a medical event. In terms of the health indicators, we've seen great improvements in health indicators. Of course, having community-based insurance is just one of the factors that has contributed to the health indicators, but it's still a contributing factor. Majority of our women that are pregnant attend antenatal care by a skilled provider, currently at over 98%. We've seen dramatic changes in the delivery at health facilities from 27% in 2000 to over 93% as per the last demographic health survey. And of course, the skilled providers has also increased because the country has invested in health workforce development. Maternal death has reduced by over fivefold from over 1,000 per 100,000 live births to currently just over 200 per 100,000 live births. Of course, no woman should die when she's giving birth. Childhood vaccinations is high at currently 96% for children with all basic vaccinations. We've introduced HPV vaccination for the girls, and the coverage is also over 98%, as well as other coverage of vaccines. In terms of trends in childhood mortality, we've also seen significant declines by almost threefold in infant mortality from 107 to 33, and the same trends in under 5 mortality and neonatal mortality. Of concern is that we seem to have plateaued over the last 10 years, and we really need to do something to address that plateau. Malnutrition is a high burden in Rwanda. Almost 1 in 3 children are stunted. They're too short for the age, but we are seeing reductions slowly happening. In terms of infectious diseases, we are also seeing significant reductions in mortality from HIV. Rwanda is nearing HIV epidemic control in terms of a 95, 95, 95, and this is on track. We're seeing the same trends for malaria, incidence, tuberculosis, where there are significant improvements in the health outcomes. Like many countries, there is an increase in non-communicable diseases, and we've actually crossed the epidemic shift. We've had an epidemic shift with non-communicable diseases now being the leading cause of mortality. Infectious diseases is still a high burden, and injuries. So we have a triple burden of disease that we need to address. And like I mentioned, the community-based health insurance was mainly focusing on communicable maternal perinatal conditions with limited coverage for NCDs. So that is one of the areas that we need to address. Other achievements, we've significantly reduced out-of-pocket expenditure when people have medical events that happen, from 28% in 2002 to less than 10% as per 2018. That's the most recent data that we have. There's also been significant increase in utilization of health services, from less than 0.5 encounters per year to around 2 encounters per year per individual. We've had private sector investment stimulated that. There's still a gap to address, but we have created incentives for private sector to invest in the health sector. Like I mentioned, the health posts are operated on a public-private partnership, and some of the services like dialysis or advanced diagnostics, the community-based health insurance actually outsources to the private sector because those services are not yet available in the public sector at sufficient amount to meet the need that is available. And increased resources for the health facility have been made available with accountability mechanisms. Other success factors, leadership, it all starts and boils down to leadership. So we've had high political commitment and leadership from the government. There have been significant investments in the distribution of health facilities, right down to the community level. The government has subsidized for the poor, and the socioeconomic classification has enabled adequate stratification of the scheme. There's community ownership. I talked about the performance contracts, the role of local leaders in the mobilization, the development in technology and inclusive financial services. So I can pay from my phone using mobile money, and other leveraging technology really has been a game changer. Of course, there's zero tolerance to corruption in Rwanda, and this scheme has been complementary to other financing mechanisms, including partner funding and performance-based financing for the health facilities. And of course, having the legal framework, making it mandatory to have health insurance was critical in the success. What are some of the challenges? Like I mentioned, we are not yet at UHC in terms of 100 along each of the different pillars of the cube. In terms of who is covered, we still have population that is not yet covered. And we recently did an assessment that wanted to identify who are these people that are not yet covered, where are they, and what mechanisms can we put into place to ensure that we get 100% coverage. We noted that some of the people are people that have been categorized as a higher socioeconomic category, but are not yet able to afford the premiums that are needed for the families. But also people with, let's say, disabilities or other key population groups that might be left behind. In terms of the services that are covered, our benefit package is still limited mainly to infectious diseases and maternal child health. So some services are not yet covered, like mainly for the non-communicable diseases, including cancers, advanced surgery, dialysis, and assistive technologies for people with disability, among many others. And we still see that in terms of financial protection, there are people that are still paying out of pocket. Of course, there's a mandatory 10% of copay at the tertiary levels, but this can add up, especially for people that have chronic illnesses or NCDs, and we still face some stock out of essential medicines and commodities at the facilities. So patients have to go and buy that from private facilities that are not covered by the scheme. I mentioned the increased burden of non-communicable diseases, and also coupled with the fact that life expectancy has really increased. People are living longer, so they are able to utilize the services much longer, increasing the cost of healthcare per capita. Other challenges include the rising quantum of claims that's influenced by the rise in NCDs, the benefit package needs to be updated to make it more comprehensive. We still have some semi-manual processes in verification, reconciliation, which may lengthen the payment to the healthcare providers. With my organization's support, we're working with the RSSB to automate some of these systems, and the claim, the payback time has really reduced from over 2 months to now just 2 weeks, which has made the facilities get money when they need it in a timely manner. We don't yet have a harmonized nomenclature. We are still at ICD 10, but the country is moving towards having a harmonized nomenclature for coding of medical acts and diseases towards ICD 11. Payment provider mechanisms, we are currently still using a fee for service where health facilities offer the services and they come and get a reimbursement. But we've found that to improve efficiency and sustainability, we need to change that to capitation, where they are reimbursed ahead of time. They're given money ahead of time, and then the health facilities state what they use the money for before they get the next advance at the primary healthcare level. And so those are some of the future perspectives that we are supporting the government in implementing. We are redesigning the provider payment mechanisms to include capitation and disease-related groupings for higher level facilities where diseases in the same category will be grouped and paid the same rate. We are enforcing the standard treatment guidelines and essential medicines lists and harmonizing the nomenclature across the different medical acts. We're also reviewing the medical package of benefits that are being offered by the community-based health insurance. We've just done an appraisal for incorporating cancers. We'll review 25 cancers. The next disease group is assistive technologies and rehabilitation services, before we look at appraising the primary healthcare service package. We are exploring new sources of contributions, including exploring raising member contributions, but also incorporation of some other taxes, maybe like sin taxes or other innovative ways of funding the scheme. And of course, really leveraging the power of IT and technology to fully automate all the systems. So I like this picture of equity versus equality. It's not that everyone needs to get the same, but they need to get what they need in order to improve the quality of their situation. And just to take us back to where we started, this is the model that we're working towards to ensure that all the population is covered with prepaid services as much as possible with minimal out-of-pocket, and covering maximally all the interventions ranging from the less costly but most cost-effective to those that are more costly, even if it may not be cost-effective, but is needed to ensure that all the citizens get the care they need at the right time, of quality, without causing any financial risk, just like my grandma, where we started off. So thank you so much. Murakoze cyane is how we say thank you in Kinyarwanda, and I'll be glad to take questions, comments within the few minutes that we have remaining. And apologies, I wasn't able to see the chat. If there's any comment in there, maybe Jess, you can highlight.
Great,
them.
thank you. Thank you so much. Before I jump in with my own questions, would anyone like to ask a question?
I would like to ask a question.
Go for it. Oh, hi.
Thank you. Hi, Dr. Cohen. Hi, Dr. Brenda. Thank you so much for the presentation and all this remarkable work that you've been involved with. It's of course it's remarkable what Rwanda has been able to do for universal health coverage. I'm still concerned from your presentation about sustainability, because when you talked about the payment premiums of $3 or even $7 for those who are employed per year, I was thinking, oh, this maybe might make sense per month, but per year. And I know you have other earmarked taxes and pretty innovative in those earmarked taxes, but it'll be interesting to see what percentage of the healthcare expenditure is coming from the earmarked taxes, what is coming from these premiums that are collected, and how much of it is still relying on donor funding, and what is the plan to move towards sustainability in the country? And another question, maybe you can write this down. What is the reception of this by the population? Is it because it's mandatory and they have to do it, or there is people, have you, the research or the information that you've received, that people actually appreciate it? And how do you get them engaged or support the community-based health insurance? Thank you.
Thank you. Jess, should I take that, or should I take
please.
a round of questions?
Yes, please, go ahead.
Yeah. Thank you so much, Satenda, for those excellent questions. One, regarding sustainability, of course, it's a concern. Up to 2 years ago, the scheme was in deficits. But last year and this year is the first time we're able to see a profit made from the scheme, where the rate of the amount of premiums was less than the expenses. And I guess this was also because of the innovative financing mechanisms that had been introduced. The first course of intervention would be to increase the premiums for the population, but we also need to ensure that we are not really passing on as much cost to the population when they are not able to meet it. So we are doing an assessment of what is the right premium that we need to be charging, that people will be able to contribute and yet contribute without really introducing hardship on them. So that is still underway, that assessment. And of course, we are looking at other innovative ways of financing, either sin taxes or other pooled mechanisms. Can we increase the percentage of the contributions from the private health insurance to the CBHI, or can we even pool the schemes so that we have just one scheme rather than operating fragmented schemes? So the government currently is operating community-based health insurance that covers mainly the informal sector, but there is another insurance for the private sector and civil servants that is actually profitable. So can we have that pooled so that the RAMA, the formal sector civil service insurance, subsidizes for the community-based health insurance without really escalating the cost to the beneficiary? We still have donor, I think around 20% of the fund is currently pooled, contributed by donors. But of course, with the change in donor landscape, that is a huge risk to the country, and we need to see how we can get more domestic resource mobilization. I think private sector engagement will also be key to contribute to the scheme, but also ensure that there is a wide range of services that is available for those that can pay using private insurance. So sustainability is a big issue from my end that the government is really considering. In terms of population, the government and the governance board actually does annual citizen satisfaction across different sectors, including health, and the citizens are satisfied, I think currently at over 80%, with the community-based health insurance. So they appreciate the benefits. Many of them have a before and after comparison, and they know that now if they get any medical event, they can go to the health facility, get the care they need without having the money to pay out of pocket at that point because they paid their premiums. So that has really been beneficial, and we've had citizen champions being the ones to go and actually mobilize others in the community that might be lagging behind. Local government involvement was also very critical with the awareness creation through the monthly community gatherings that we have, and really educating the public about the benefits of enrolling in CPHI. Much as the health insurance, having health insurance is mandatory, it's not mandatory to enroll in CPHI. So citizens have an option on which scheme they can enroll in. Yeah, I think those were the 2 questions.
Yes, ma'am. Thank you.
Thank you. Yes, Valerie.
Thank you, Dr. Kateera. I really enjoyed hearing about Rwanda's experience with UHC. So just to follow on these questions about sort of sustainability and innovative financing at the same time that you're trying to expand coverage for conditions, I was curious if you could talk a bit more about what the plans would be to try to expand coverage for NCDs, sort of as that epidemiological transition is happening. You mentioned that you're looking at reviewing cancers and some technologies for disability, but I'm curious if you think it would be feasible to start expanding into NCDs that are chronic, expensive, like stroke or hypertension, mental health issues, and are there plans to do that in the near future, or is there a lot of concern that the cost would be so great that premiums would become unaffordable?
Yeah, again, excellent contribution and comment, Valerie. NCDs, the cost of care for NCDs is, like you noted, much more expensive than the communicable diseases or the maternal child health. So of course there will be cost escalation when the benefit package is increased. So the government approach has been to focus on prevention as much as possible. So we have prevention measures that have been put into place, including every 2 weeks, the roads are closed off to encourage increase in physical activity from the population. There is an annual health check that is covered by the CBHI to really detect NCDs early, and that's free to the population. And of course, awareness and education on the risk factors, smoking, exercise, diet, to really bring down the burden of NCDs in the country. Some of them, like for mental health, given the history, mental health challenges are a big priority in the country, and that is covered by the scheme in terms of screening and treatment. Like you mentioned, cancers, diabetes, hypertension, and other NCDs that are not yet fully covered, we are reviewing. Of course, we have to do a cost effectiveness and come up with a prioritization criteria of which what service should we cover that is not going to really increase the cost within the available resources that we have, and then identify the gap that is needed and try and do the revenue raising to meet that gap. But I think the core is that health care is a right. It's not a service, and citizens should be covered. And that is the aspiration that we need to be going towards. Yeah, so it's that balance that we have to meet.
Thank you so much.
Was there a second part of your question?
No, that was it. Thank you so much.
Yeah, thank you.
For those who joined late, I'm Dr. Bethany Rose Dodman, and along with Dr. Cohen, I direct this Harvard Lead Fellowship that Dr. Kateera is a part of, and I'm just going to be facilitating the last few minutes of the Q&A. So would love, you can throw your questions in the chat or just raise your hand, whatever you prefer.
BR just mentioned that had some questions. Was she able to leave them with you before she left?
We had talked in advance of your presentation about some questions that we were just thinking of, just knowing the title. And so since I have the floor, I guess I'd love to ask, are there aspects of this universal health coverage model that are you specific to Rwanda? Or are there ways in which you looked? I know you've done work in other countries as well, that you used your expertise in other situations to sort of borrow those findings, or ways in which it was unique. I'd love to hear about your other experiences as well.
Thank you so much. So I think all countries are implementing some kind of UHC model, and many countries are now moving towards health insurance as a preferred way of offering health services to the population because of the advantages that have highlighted. Many countries are still using fee-for-service or subsidized free services to the community, but that is still not sustainable in the long run, especially if they are very donor dependent or donor funded for those services. So there are other innovative financing mechanisms that have been recently. Kenya introduced a development impact bond for adolescent sexual reproductive health services, and other countries have blended mechanisms of financing for their health services. Yeah, so there is different models that are available, but I would say that having health insurance and really revising the package and ensuring the population is covered would be the best way forward for low middle income countries. And Rwanda is not unique towards this. Ethiopia has implemented this. Ghana has implemented this. Nigeria in some of the states. And I think Zambia has also recently introduced. Uganda has been thinking about this for the last 20 years or so, but not implementing. So different countries are at different levels. Yeah, thanks.
That's really helpful. Thank you, Dr. Kateera. I think we may have time for one more question if there are any burning questions. I see one in the chat from Emmanuel. Thank you for your talk. And are the premium rates dependent on income level?
Thank you, Emmanuel. Yes, the premium rates are dependent on the income levels. So every citizen belongs to a socioeconomic category, and that is determined by the level of income that the household is able to generate per year, the assets that they have available, the kind of infrastructure that they have access to, whether they are houses or farms or whatever. And depending on those different variables, there is a categorization done that determines the socioeconomic status. So the premium rates they follow a sliding scale depending on the socioeconomic status and income level, with the lowest category currently paying $3 per year, and the government subsidizes that at 100%. And then for category 2, 3, 4, they pay $3 to $7, which is under review for their premiums. You're welcome, Emmanuel.
Yeah, I just wanted to follow up. So does that, when you say the government subsidizes 100%, that means they pay nothing, like $0?
Yes, they pay nothing.
Okay.
For that. Okay. Yeah.
Great, maybe one more question. we have time for. Well, selfishly, maybe I will ask the last question then, if you don't mind. On the slide
Yes.
mentioning success factors, you talked about the high political commitment, that the government was really engaged. And I'm wondering if there were ways, how did you facilitate that, or how are you able to take advantage of that? That seems like a huge boon.
Yeah, Rwanda, this is a very high on the political agenda, right from all levels, president's office, all the way right to the community. And this has been a huge success factor. Like I must say, there is accountability mechanisms right from the highest levels where the mayors have to sign performance contracts with the president every year. And CBHI coverage is one of those indicators that that are included within the performance contracts that they sign. And because it's a there is government ownership, they are leading the reforms across the different government entities that I mentioned, whether it's Ministry of Health, Ministry of Finance, Ministry of Local Government, and they are working together. So they are not working in silos. There is coordination across the different ministerial bodies and institutions in the country, but also within the ministry, there is a health sector working group, of which we are part of, that contributes technical input with the donors providing for some of the funding, and civil society members, academia, all on the same table, talking about the challenges and coming up with innovative ways of addressing the challenges. So really, the political leadership has catalyzed the success of CBHI, and for sustainability is very critical, because then the government will have to take this on 100% down the road for full government funding.
Wonderful. Maybe in the last minute, we will sneak in a final question from Nellie. That are there diseases or conditions that you're tracking as performance indicators in terms of health impact?
Yes, so we have a robust M&E system that not just for CBHI, but generally health sector indicators that we track, and we on real time. So there is primary data collection from the electronic medical records, but also the community systems and surveys that we put into place, such as the demographic health survey, and that tracks different health indicators. And we review the data at a minimum quarterly through the joint sector review meetings. But of course, there are technical teams that are in charge of data, evidence collection, generation, analysis, and using that evidence to inform the policies and programs that need to be put into place. So there is overall health impact tracking, not just impact, but even the outcomes and some of the process indicators as well, at the central level, at the decentralized level, within the district, all the way even down to the community level.
Wonderful. Well, maybe we will close it out there. Thank you all for joining us today. And thank you so much, Dr. Kateera, for this presentation. We welcome you to join GHP on Thursdays at 1 for more Brown Bag Seminar Series. And I will just plug, there's another one of our 2023 lead fellows, Dr. Marie-Rosaline Belizar, who is an emergency preparedness lead at the WHO in Central African Republic. And she is presenting in 2 weeks on November 30th on what we know and don't know on how to effectively engage the community in health security. So thank you again, Dr. Kateera, so much for sharing your experience, and thank you everyone for attending. Have a great day.
Thank you. Have a great day too. Bye.